Hey everyone, and welcome. If you're a pathology trainee, you know that feeling when a big thymectomy specimen lands on your bench. It can be a little intimidating, right? Well, you're in exactly the right place. Today, we're going to decode the latest CAT protocol for thymic tumors, that's version 5.0.0.0, to give you all the confidence you need, from the grossing bench all the way to the microscope.
So what's the big deal? What's new? That's always the first question, isn't it? Well, this All Explainer is really built around the latest updates, especially the mandatory switch over to the AJCC 9th edition staging system. Let's get you completely up to speed so your reports are on point from day one.
All right, here's our roadmap for today. We're going to start with the basics. When to even use this protocol. Then we'll get into the non-negotiable rules of synoptic reporting, dive deep into describing the tumor itself, and then pull it all together with the brand new AJCC 9 staging. We'll finish up with ancillary studies and that super important comments section.
Okay, first things first. Before we can even think about the details, we have to make sure we're using the right tool for the job. Understanding the scope of this protocol, that's the absolute critical first step for any specimen that lands in front of you.
So this is super important. This protocol is specifically for resection specimens. We're talking your thymectomies, partial or complete. It's for the epithelial tumors, things like thymomas and carcinomas. Now, what it's not for is just as crucial. Don't use it for biopsies. Don't use it for cytology. And if you've got other stuff in the mediastinum like a lymphoma or a germ cell tumor, nope, they have their own protocols. Keep them separate.
All right, let's talk about the report itself. This isn't just creative writing, where you can describe things in a long paragraph. Cancer pathology has a standardized language, and for us, that language is synoptic reporting.
Synoptic reporting is really the backbone of modern cancer pathology. It's not just a nice idea, it's a requirement for accreditation. And there's a great reason for it. It makes sure that everyone on the patient's care team, the pathologist, the surgeon, the oncologist, is reading the exact same data points. It's all about getting rid of any ambiguity and just standardizing care.
And here it is. This is the golden rule right here. It's so simple, but it is absolutely strict. You have the data element, you put a colon, and then you put the answer. That's it. Each one of those gets its own line. This structure is totally non-negotiable, and it's the foundation of your entire report. Master this, and you're already halfway there.
Okay, now for the fun part, the heart of the matter, the tumor itself. Now that we know we're using the right protocol and the right format, we can finally start describing what we're actually seeing, both grossly and under the microscope.
Just think of this as a 4-step checklist for every case. First, what is it? We need that specific histologic type. Second, how big is it? Get that measurement of the greatest dimension. Third, is it getting into vessels? You have to assess for lymphatic or vascular invasion. And finally, where is it going? You have to document every single adjacent structure it's invading.
When it comes to thymomas, we're using the WHO classification. You're going to see a whole range from type A all the different B types. Now, a really key point here is about type AB. It's not some mix of A and B, it is its own unique thing. Oh, and if you see more than one pattern in a tumor, say a mix of B2 and B3, you've got to estimate the percentage of each in your report.
Thymic carcinomas, on the other hand, are a whole different beast. They are a really diverse group of pretty aggressive tumors, and they often look just like carcinomas you'd find anywhere else in the body. The list is long, everything from the pretty common squamous cell carcinomas to the rare but really important NUT carcinoma, which needs special testing to confirm. Okay, so we've characterized the tumor. Now we need to define its boundaries. And let me tell you, margins and lymph nodes are two of the most critical pieces of information we give to the clinical team. This directly affects whether a patient is going to get more treatment, like radiation or chemo.
When you're looking at margins, you have to be precise. It is not enough to just say negative. You've got to identify the closest margin and then measure that distance in millimeters. This is absolutely crucial for the surgeon. And, of course, if a margin is positive, you have to say exactly which one. There's no wiggle room here. The completeness of the resection is a huge prognostic factor.
And for lymph nodes, the process is just as systematic. We need to know the total number you found and looked at, and then the total number that actually have tumor. But here's the key. You also have to specify the location of the positive nodes. Are they in that anterior parathymic group right there? Or have they spread to the deeper intrathoracic or even the cervical chains? That distinction is everything for PN staging.
All right, we've gathered all our data. The histology, the size, the invasion, margins, nodes, all the puzzle pieces are on the table. Now, it's time for the final synthesis. We're going to take all those pieces and put them together to get the official pathologic stage using the AJCC 9th edition.
You know, to really understand where we are now, it helps to know where we came from. For years, everybody used the Massa-Okakoga system, but honestly, it was kind of ambiguous. Then, AJCC 8th edition came along and gave us a formal TNM system, which was a huge leap forward. Now, the 9th edition refines that system, especially in the T categories, and it is the mandatory standard for this protocol. Massa-Okakoga is officially out. And just to hammer this point home, the protocol version we're talking about today, version 5.0.0.0, is the one that mandates using the AJCC 9th edition. So when you're using this protocol, you have to use this staging system. No exceptions.
This table gives us a really fantastic high-level look at T staging. Think of it like a ladder of invasion. So PT1 is localized. It's just hanging out in the surrounding fat or pleura. PT2 means it's hitting more significant structures, like the pericardium or the lung. PT3 means it's invading major vessels like the SVC. And PT4, well, that's when it's getting into the great structures, the aorta, the heart itself, or the trachea.
Now, the N category. This is refreshingly straightforward, which we love to see, right? Remember those nodal locations we talked about? This is where that pays off. If the tumor is only in those anterior perithymic nodes right next to the thymus, it's PN1. Simple. If it has spread out to the deeper intrathoracic nodes or up into the cervical nodes, it's PN2. It's a simple distinction, but it's vital for prognosis.
We are almost at the finish line, but sometimes just looking at the H&E slide isn't quite enough to be 100% certain, especially with all the different things that can pop up in the mediastinum. That's where our ancillary studies come in to really clinch the diagnosis. Think of this slide as your go-to IHC cheat sheet for the thymus. So, for instance, you're staring at a sea of lymphocytes and you're thinking, is this a thymoma or a lymphoma? A cytokeratin stain will light up those epithelial cells and give you your answer. CD1A and TDT are fantastic for proving that the lymphocytes are immature thymocytes, a hallmark of thymoma. If you're thinking carcinoma, CD5 and CD117 can be helpful. But be careful, some type B3 thymomas can be positive, so you have to interpret with caution. And for those really tough cases, something like SAL4 can help you rule out a germ cell tumor, while NUT IHC is the one and only test to confirm NUT carcinoma.
And please, never underestimate the power of the comment section. The synoptic report is rigid, but this is where you can add the nuance. Use it to tell the story. Explain why a margin was tricky to assess. Detail the percentages of different histologic patterns, or communicate anything you think is critical for the clinical team to understand.
So what's the bottom line here? This protocol isn't just a bunch of rules to memorize, it's a framework. It's the standardized structure that makes sure every single patient with a thymic tumor gets a clear, comprehensive, and consistent pathology report. And that is the absolute foundation of high-quality patient care.
So, I'm going to leave you with a little challenge. As you go through your training, think about this. With all the mimics and all the morphological overlap, which specific subtype of thymic carcinoma do you think is the most difficult to diagnose, and why? The answer to that question is what's going to take you beyond the protocol and into the real art of pathology. Thanks for joining me today.